Here are my disclosures. So to start, obesity is defined by a body mass index of at least 30. It's found in 13% or 650 million adults worldwide. Is a little more common in women, and importantly, its prevalence has tripled since 1975. It occurs in more than 30% of adults in 7 countries, with the USA at the top at 36%. A lot of European countries and Australia in the 20% region. And the only reason it's not that common worldwide is because a few very large countries such as China and India have much lower prevalence rates. In HIV positive adults, the prevalence varies in the 4 studies published between 15 and 39%. And the only study to compare adults with HIV and adults without HIV, the POPPY cohort, actually found that obesity was more common in those who did not have HIV. Additionally, 40% of adults are overweight with a BMI of at least 25. Obesity matters. It causes a lot of complications, largely due to its secondary hypertension and diabetes, which causes macro and microvascular disease, as well as chronic kidney disease. Additionally, there's degenerative arthritis, many different types of cancer, obstructive sleep apnea, fatty liver disease, and some complications of pregnancy. Obesity kills. If your body mass index goes up by 5 kilograms per meter squared, your risk of death increases by about 30%. And the graph on the right-hand side of the screen shows that. And the graphs look very similar regardless of where you are in the world, whether you're a man or a woman, or whether you're old or young. This increased deaths from obesity kills about 4 million adults a year. And not all of those people are obese. Some of them are in the overweight category. About 70% or 2.8 million deaths are due to cardiovascular disease, and about 85% occur in low to middle income countries. So this is a global problem, not a first world problem. To my way of thinking, there's no reason to believe that obesity in HIV positive adults won't have the same risk as it does in the general population. So let's now turn to the antiretroviral story. And here are 2 cohorts on the left of initial therapy and on the right of antiretroviral switching, which demonstrate weight changes with therapy. So with initial therapy, you see most of the weight gain in the first year and a greater weight gain with integrase therapy in blue versus protease therapy in green and non-nucleoside in orange. From years 1 to year 5, there's a more gradual increase in weight, but do remember that in the US, where this cohort originates, the average adult without HIV gains half to 1 kilogram per year. So some of this weight gain is just weight gain due to healthy survival. On the right-hand side, we see the switch from a TDF and efavirenz-based regimen to integrase inhibitors, largely dolutegravir. And on the top right, you'll see that weight gain occurs more in people who did the switch than who didn't, but this is non-randomized data. And on the bottom right, there's more weight gain in those who switch to dolutegravir rather than to other integrase inhibitors. But again, it's important to acknowledge that there was not just one drug switched here, because many of the patients not only switched from efavirenz to an integrase, but also switched from TDF to another nucleoside. Gilead has merged the data from 8 of its naive trials with the 16 arms there shown on the left to look for risk factors for weight gain in adults initiating therapy. And on the top right, they found 5 clinical factors: a low CD4 count, a high viral load, a high body mass index pre-treatment, being a woman, and being of black race. The antiretroviral factors were bictegravir or dolutegravir and rilpivirine versus efavirenz, and TAF versus abacavir or TDF. The TDF switch has been looked at in one large cohort, the OPERA cohort, where adults switched from TDF to TAF whilst maintaining their other medications. And regardless of the anchor drug class being used, an integrase, a non-nuc, or a boosted PI. In the first 9 months after the switch, as shown in the figure on the left, there was an increased weight of about 2 to 2.5 kilograms, and then the trajectories became very similar to the trajectory prior to the switch. Then comes the advanced study, which generated a lot of interest and many new findings. Firstly, that the weight continued to increase over the first 3 years and doesn't really seem to be plateauing. Secondly, there's a difference between the 3 regimens used, with more weight gain with TAF, FTC and dolutegravir, intermediate weight gain with TDF, FTC, dolutegravir, and the least weight gain with TDF, FTC, efavirenz. So there's a difference between TAF and TDF and a difference between dolutegravir and efavirenz. Thirdly, the weight gain was greater in women than in men. Fourth, as shown in the body composition data on the top right of your screen, that most of the weight gain is fat rather than muscle. And importantly, the green boxes show that there's an increase in limb fat. So this is not HIV lipodystrophy again, this is a generalized fat gain. And lastly, on the bottom right, you can see that the people who are polymorphic for the CYP2B6 mutation that drives efavirenz metabolism, the slow metabolizers who presumably have the highest efavirenz concentrations have the least amount of weight gain. So more efavirenz, less weight gain. To my way of thinking, one of the unnoticed findings from ADVANCE was the changes in ADVANCE relative to the general South African population, where of course the study was conducted. So here are the changes at weeks 144. Relative to baseline, shown in white, are the 3 treatment groups in orange, green, and pink, with men on the left of your screen and women on the right. The 2 yellow columns show 2 different healthy adult population data sets from South Africa, and the blue line attempts to show you the mean of those 2 different studies. And so what you can see is that, yes, there's a weight gain, yes, there's a difference between the regimens, but the weight gain is basically returning to what is normal in South Africa, with one exception on the right where the dolutegravir TAF, perhaps there's a little overshoot beyond normal. So perhaps the reason women gain more weight in ADVANCE than men is because South African women have much higher body mass indexes than do South African men. Another important point to note is the difference between mean and median changes. So here is one illustrative study, the DRIVE study, where at week 96 in the red circles, you'll see that the mean changes, the mean increase in weight is substantially greater than the median. So if a mean value is higher than its corresponding median, that tells you that there are outliers, and that therefore there are people in this study who are not gaining 2 kilograms, but are gaining 5 or 10. And to my way of thinking, it's critical that we start to understand who those people are. Now let's turn to some of the switch studies. On the left is the STEEL study, which is quite an old study, but there it is, a greater weight gain in people who switch to abacavir 3TC while undetectable versus those who switch to TDF-FTC. On the right, the TANGO study, TAF-based therapy being switched to dolutegravir 3TC dual therapy with no weight gain difference, 0.8 kilograms in both groups. But of course, you're removing TAF, which has been associated with weight gain, and starting dolutegravir, which has been associated with weight gain. So the individual drugs have not been assessed. And what we need are studies where individual drugs are being properly studied. So here I've attempted to merge the published and presented data on the naive studies on the top rows, the switch studies in the center, and for lack of time, I haven't presented the PrEP studies at the bottom. Firstly, you'll see that the weight increases, mostly over 96 weeks, are substantially greater in the naive studies than if in either the switch or PrEP studies, reflecting some return to health. The colours show you in pink that TDF and efavirenz have less weight gain than their comparators, in blue that TAF has more weight gain than its comparators, and in yellow that integrase inhibitors have more weight gain than its comparators as well. So what's the significance of all of this? So if I take the average Australian man who weighs 86 kilograms and has a BMI of 27.8, and he starts TAF or an integrase, whatever regimen, gains 2 kilograms, his BMI goes up to 28.5, but it really doesn't change. If he gains 10 kilograms, his BMI is 31 and he's now obese. And to increase his risk of death by increasing his BMI by 5, he needs to gain 15 kilograms. But please remember, 40% of weight-related deaths globally occur in adults who aren't obese. So we still need to pay attention to those who are not in the obese range. And of course, there's morbidity related to weight gain that can occur with smaller BMI increments. The ADVANCE study has attempted to model its week 96 data in the 3 regimens for men and women. And on the top 2 lines, just a reminder of what the weight changes were at 96 weeks and what proportion of adults became obese over that time, with up to 28% in one of the groups in the women. The corresponding cholesterol, glucose, and systolic blood pressure changes are shown, and I think you'd agree that those changes look fairly modest. At the bottom are shown the changes in cardiovascular risk using 2 equations, as well as a diabetes risk. And these are 10-year risks that are being increased by the weight. And for cardiovascular risk, you're talking between 1 and 4 additional cardiovascular events per 1,000 years of treatment. And diabetes, it's somewhere between 5 and 9 new diabetics per 1,000 years of treatment. So a fairly low risk, but of course this is a young population, so it may not apply to others. So what can we do? It's very easy to tell our patients to eat less and move more. And the figure on your right shows you how that works. Basically, to get rid of fat, you need to use oxygen and convert it to carbon dioxide and water. So if you sit still and don't eat, you will have a resting metabolic rate that will convert that. And if you undergo physical activity, you'll accelerate that process substantially. What about switching treatment? There are no randomized studies to show us what happens when you switch any medication and its effect on weight. There's nothing on drugs that can affect body weight, such as some of the newer diabetic drugs. And there's only case reports on bariatric surgery. The WHO recommend that we reduce our energy intake, but that sort of general advice yields minimal weight loss, about 0.3 of a kilogram at 6 months. They also recommend regular physical activity, about 2.5 hours a week. Specific diets of people who agree to be enrolled in randomized trials and are trying to lose weight will generally lead to 4 or 5 kilograms of weight loss at 6 months, with a mean 3 kilograms at 12. The recent New England publication shown on the right demonstrates what can be achieved with both reduced intake and an exercise program, with about 8% loss at 6 months, becoming about 6% at 24 months. So pretty good outcome. And on the bottom right, you can see that that outcome was not really affected by what age you were. Importantly, this study was performed in community practices, so it should be achievable for all of us. So in conclusion, weight gain in HIV positive adults is generally not that severe after 2 years, but outliers clearly exist, and we need to learn who those outliers are. It's likely to cause more non-communicable diseases and death, even in those who don't become obese. It appears to be accelerated by integrase inhibitors and probably TAF, and inhibited by TDF and efavirenz. But importantly, most of these studies have significant limitations, and I struggle to believe that 3 different drug classes can all affect the one outcome. We will see. The weight gain is greater after ART initiation than with switching or with PrEP, partially reflecting a return to health, or perhaps better phrased as a return to societal norm. We have many unknowns, such as who are the outliers, what happens to weight gain after 2 years, what are the mechanisms, how do we prevent or treat this, and what are the clinical consequences. Our mechanisms will need to account for the outliers, and good answers will only come from properly designed clinical trials. Thank you.